Hello and welcome everyone. Thank you very much for joining us this evening for our online talk on hip pain and soft tissue problems. I'm Katie, one of the members of the marketing team, and I'm delighted to be joined by Mr Tofunmi Oni, one of our consultant orthopaedic surgeons here at the Horder Centre. Mr Oni specialises in hip and knee procedures, including hip replacement, knee replacement, meniscus tear repair, knee arthroscopy and revision hip replacement, alongside his expertise in knee injections. A reminder that this webinar is live and the recording will be emailed to you tomorrow. If you do have any questions for Mr. Oni during his presentation, please type them into the Q&A box so we can address them during our segment later on. Once again, thank you all very much for joining us, and please welcome Mr. Oni.
Good evening, one and all. So today I want to talk about something it's been inspired by a very common presentation that I see, common questions that I see about the hip from my patients, and that's generally around where hip pain is and what it means when hip pain is in different places. And so it's something that very much I've talked about recently, which is why inspired me to mention this to the guys to give this talk. So we've titled it sort of modern approaches to the hip pain and soft tissue problems. And so that's an ode to the fact that the hip joint itself is a bony construct, but it's surrounded by soft tissue sort of elements, so tendons, ligaments, and muscles, which make the hip function. So just a quick talk about what we will cover. One is just hip pain as a symptom, where typically it is, and what that then points to. And then I wanted to look at some very specific causes of hip pain, including osteoarthritis, bursitis, what that means, tendon problems around the hip, when there's sort of typical and atypical presentations of the hip, and as well as treatments of these various bits of pathology. So the first thing to say is, where does it hurt? And this is a very simple schematic sort of diagram that I've sort of broken down into front, side, back. And the reason why I kind of did that was because often I see patients in clinic who tell me that their hip hurts and immediately point to a place that I don't consider to be the hip joint, but it's a place that a lot of people do. So very much so looking at the simple diagram. Number two, I would say, is where a lot of people would say my hip joint, so pointing to the side. But that's very much not where the actual articulating part of the hip joint is. It's actually closer to where number one is on that diagram that says front, or even number four rather than number two. But as a very simple way of looking at things that I will go into more detail after this, if it's the front of the hip, so that's number one or between number one and two, then that tends to be where you get pain in hip arthritis and certain types of tendinopathy and bursitis. Again, I'll go into this in more detail in a minute. The side tends to be where a lot of the most common type of bursitis is. And the back, again, is where you can get a lot of tendon sort of problems, as well as other things that can actually mimic hip pain. So where is the hip joint really? I love this diagram because really it says everything about where it is. The hip joint is not on the side. It is closer to the groin. And often I find that, in fact, in my clinic today, I had this conversation. Often people feel like they've pulled a muscle in the groin, or they have certain pains in and around the groin or inner thigh that didn't automatically register to them as something that might be wrong with their hip. But it certainly would if you spoke to a hip surgeon like me. So that diagram is really good to just keep in mind. Before we dive into those specific pathologies, this is a slide just saying when the hip is not the problem. So common mimics, because often we can have anatomical situations that help us spot certain patterns. So for instance, a lot of the time, patients with hip pain or hip pathology can present with knee pain, and that's because the nerves that pass the hip carry the pain sensation down. Sometimes it's nerve pain from the back, and sometimes it's referred from sort of the buttock area, where it can actually be more hamstring trouble. So there are a lot of sort of mimics, but these are a little bit, we'll say, more anatomically focused, rather than things we see all the time, I would say. Now there's the do not miss, and these are the rarer ones, but night pain has nothing to do with you sort of position. But I would worry if anyone had these sort of pains with unexplained weight loss or a history of cancer, or a sudden inability to weight bear. Often it is more insidious, or a painful hot swollen joint that made people unwell. These are what I would say need urgent review. But going back to the pathologies that we mentioned, osteoarthritis of the hip, extremely common. On the right hand side is an X-ray of the pelvis of this individual, and on the left hip, which is, as you're looking at it, the right, that shows severe osteoarthritis, which can be seen by looking at a complete loss of the space between the spall and the cup. And this gentleman has actually lost his sphericity of the cup as well. So clear osteoarthritis. So when a patient like that comes to see me in clinic, the typical presentation that I would expect is they have a deep sort of sense of groin pain or inner thigh pain that's worse on weight bearing or activity, worse at the end of the day, or at night time, which is extremely common because it's the culmination of the day's activities that build up to the night. Often they have morning stiffness or stiffness after long periods of immobility, a loss of movement, rotation especially, and the most common, we'll say, activities of daily living that people struggle with is the bending over activities, putting shoes on, socks on, getting in and out of cars, and they progressively get a limp as the symptoms progress. So that's what I would consider to be typical symptoms. Now, atypical symptoms would be the pain solely felt in the knee, rather than anywhere higher up towards the groin, or indeed the buttock, or indeed a pain that sort of is at the beginning of activity and then completely settles down over time, or younger patients after injury. So that's a little bit more of an atypical presentation of this. Treatment options. We always talk about climbing the ladder when we're offering treatment options. The first line is all about conservative measures, so keeping mobile, weight management, physiotherapy to build up the muscles around the joint and help to offload the joint, and simple analgesia, or paracetamol or anti-inflammatories. Then the next step on from that is things like walking aids and an injection, which usually provides a temporary relief, and more of an adjunct to physiotherapy rather than an actual treatment. And then the definitive treatment is replacement surgery, like a total hip replacement. The next pathology I wanted to talk about was bursitis. Now, a bursa is an extra layer of tissue and fluid that cushions any hard surfaces of bone that are particularly close to articulating areas or close to the outside. So, for instance, on the side of the hip, there's a bursa there over that bone, which is called the trochanter. Even coming away from the hip completely, the elbow has a bursa. Your heel bone has a bursa. Anywhere where you might see, we'll say, lumpy bits, parts, you have extra layers of tissue and fluid that cushion things. But when this is irritated, it becomes inflamed, and that's what bursitis is. So you talk about trochanteric bursitis, which is what that picture on the right-hand side is alluding to, which is where the muscles that are around the hip attached to that large area of bone called the trochanter. There is a bursa over that point. But if these muscles become inflamed, they inflame the bursa in turn, and that is what trochanteric bursitis is. And that's the most common reason that patients I see get pain on the side of the hip. Then the next type of bursitis, would say, is iliopsoas. Now, the iliopsoas is a type of tendon that runs over the front of the hip and has a corresponding bursa. And I think the next slide will actually show where this is. We'll find it in a moment. And the ischial bone, which is around the back of the bone of the buttock where individuals sit on, that also has a bursa. And wherever there is a bursa, which tends to be where tendons are attaching to, there is a propensity to be prone to inflammation of that point with the tendons and the bursa around it, and therefore a bursitis. But the concepts of treatment are the same, regardless of where the bursitis is, which is you try and settle it down in the most benign way, I suppose, which is rest and potentially even icing it if it's not a structure that's deep, and essentially physiotherapy to try and build up the muscles of the tendon it belongs to, and short-term sort of courses of anti-inflammatories. And when it doesn't settle, that's where injections come in as an adjunct to physiotherapy, or more novel things like shockwave therapy, and surgery is really something that's not really done for this procedure at all. Really, it really is a last resort. So going back to the iliopsoas tendon, it's just depicted in a picture on the right-hand side. It's a combination of both the psoas and the iliacus, forming a tendon that runs over the front of the hip joint, as you can see on the right-hand side, and joining to just beyond it. And that area has a bursa. That tendon can become inflamed and lead to a bursitis. Now, how it presents, it actually completely can mimic arthritis, because you can also get pain at the front of the hip, which is with arthritis you can get groin pain in the same way. The difference tends to be that when this tendon is in use is when it tends to be the most aggravated. And so generally lifting your knee up, especially against resistance, you might feel that that's when the pain is, and other times it completely settles down. But this is where reviewing a surgeon to look at the nuances of this is imperative, so that this isn't attributed to arthritis when it could be just a simple tendonitis or bursitis. And treatment, again, we talked about physiotherapy to build the muscles up around the hip joint, targeted injections mainly as an adjunct to physiotherapy, and the last resort, that tendon can actually be completely resected. And that sounds fairly drastic, but if the tendon's cut, then it's no longer under tension, and then it forms a scar tissue over a longer excursion, which sometimes actually completely settles down the symptoms. So gluteal tendinopathy just means wherever the gluteal tendons attach to, which is the side of the hip. And we've talked about this, they attach to the trochanter, and that leads to a trochanteric bursitis. And so the notion of a trochanteric bursitis and gluteal tendinopathy is very much a blur, which is why these days we tend to use the broader term of a greater trochanter syndrome, rather than using a gluteal tendinopathy or bursitis, or trochanteric bursitis, which are older terms. But in terms of how it presents, Again, we talked about pain on the outside, and the treatment is much in the way of any other type of bursitis or tendonitis. One of the other things we talked about in terms of pathology was a proximal hamstring tendinopathy. So where your hamstring tendons start from is very much where your sit bone is, and if you have a bursitis or tendonitis around that area, then you can have deep pain around the sort of low buttock, especially when sitting down on hard seats or using your hamstring tendon muscles. But again, this can also mimic where hip pain can come from. So it can mimic things like arthritis, because some people atypically present with arthritic pain round towards the buttock. But again, those being able to tease it out is all about when the pain is worse, and what activities that are being done when the pain comes on. And again, the treatment, once again, very much a broken record, is pretty much the same. You ease the aggravating load, progressive strengthening with physiotherapy, targeted potential injections, and surgery really is a last resort again. So just a bit of an overview, which is going to be pretty much my last slide. Just as a summary, I wanted to talk about this because of a lot of a misunderstanding from my patients about where hip pain is coming from, and what can be involved, and what arthritic pain looks like. But I've just put it into this table to almost to simplify things, to say location, what's most likely, what it's worse with, and what the first treatment is. So in the front of the groin, most likely either the arthritis, in terms of wearing away of the ball and socket joint, or the psoas tendon being irritated, because that's the tendon that runs over the front of the hip. It's worse with weight bearing and use, or lifting your knee up, especially resistance in the case of the psoas. And first line, again, conservative measures, physiotherapy, all the way up to injections and replacement if it's arthritis. The second line is location. Pain on the side of the hip. The most likely thing is gluteal tendons irritation and bursitis, in other words, the greater trochanter syndrome. And it's worse with pressure on it. So often people don't like lying on that side. It's also worse with sort of mobility. But the treatment, again, physiotherapy. And if the pain is on the sit bones or right in the buttock, then the most likely thing is hamstring origin. So that's where the tendon starts from, bursitis. It's also worse with certain types of mobility, especially explosive movements. And the treatment's the same really as the greater trochanter syndrome. And then pain in the knee or the thigh, it may well be referred from either the hip or spine, or indeed the knee itself. Let's not forget that the knee exists and can give problems. And it's worse with, so I've put on there varies with the source. So very much depends on the source as to what will make it worse, and those are the clues that you can get by during a consultation with an individual. The key thing is examining, the hip as well as the back to try and form the full picture before diving in with treatment. So key takeaways: hip pain is a symptom. It is not a diagnosis in of itself. We have to match the site to the source. One of the things I want people to take away is pain on the outside of the hip is most likely a bursitis and not hip joint problems. Watch for the mimics in terms of knee pain and spine involvement, and most of the time to treat things we start simple: load management, physiotherapy, and then build it on from there. Thank you very much. So I'm happy to take questions, or I'll hand back over to Katie.
Thank you, Mr. Oni. I'm sorry for the slight delay there, and I'm sorry for a couple of you that have been experiencing difficulty seeing the slides. I'm just going to, I've got Marta here in the background, trying to go through, she's sharing the slides her end, Mr. Oni. So I'm wondering if they do start to move, which I'll see in a moment, I may ask you to just go over the top level. I'm so sorry, we've still got quite a lot of time. So maybe, no, she's confirming they don't move. Okay, that's fine. It's just some people have experienced difficulties tonight. It seems fine from our point of view, but we'll just try and figure that one out. It has been recorded, so you all will receive the recording of all of that information. So apologies to those who was experiencing difficulties. It does mean that we can go on to questions, which some of you dropped in now, and we had a couple come in advance. So if I start with, after an injection for bursitis, what is the next step? As of yet, the injection has not worked.
So it varies slightly depending on where the bursitis is, but in terms of broader concepts, the injection is not the treatment. Usually the injection is an adjunct to the treatment, which is progressive overload type of physiotherapy. So bursitis it can be an extremely stubborn pathology. Often, it lingers. Often it stays with people for long periods of time. There's a lot of back and forth between patients and GPs and surgeons and things and things like that. And unfortunately, there's no silver bullet. But the key thing is the injection is not designed to treat the problem. It's designed to help you. It's designed to facilitate the physiotherapy, which usually will more effectively treat the problem. So the unfortunate reality is the injections don't work in everyone. And in people where it doesn't, we have to make sure that it's not another pathology involved. Because like I said, there's lots of different areas that are overlapping. And so we want to make sure that we are treating the right thing and therefore injecting the right thing. And that's a reason why injections can also be good, because if it doesn't work at all, it may actually be telling you that's not where the problem is. It may be coming from somewhere else. And so it guides us it guides that diagnostic process to try and find where the problem is coming from. But I would suggest hanging on in there, keep going with the exercises, and if things really aren't improving, then it might be time to look elsewhere.
Okay, fantastic. Next one says, how to release sharp groin pain that comes and goes.
Yeah, so this is another it depends type question. Depends on what the cause of the symptoms are. Now, sharp pain that comes and goes suggests more on the psoas tendon end of the spectrum. However, you can have hip joint sort of sharp pain either when bits of debris get caught in the hip. You can have a similar sort of thing. It's all about building the larger picture, which comes with talking to a patient about all the other times when the pain is there and exactly where it is, and forming a fuller picture of when it might what might be causing it, and therefore how we might solve it. So unfortunately, it's not something I can sort of directly answer for sure without having a bit more information from the patient. But it also leads me into a really sort of out of the box reason for groin pain, which is actually which is nothing orthopedic at all, nothing to do with anything I've said today. Another reason people get groin pain type issues is hernias. And when we exhaust all of our sort of parameters of anything musculoskeletal that might be causing symptoms, then our typical out of the box is, well, do you need to be seeing an orthopedic surgeon like me, or do you need to be seeing a general surgeon to make sure you don't have a hernia which is mimicking these symptoms? So unfortunately, I can't really answer that without a lot more information and someone in front of me to speak to and examine.
Okay. Does an X-ray always show the extent and severity of hip arthritis?
So there's an age-old adage that whenever there's always used in anything, it usually means that's not the case. So the reality is an X-ray is a 2D representation of a 3D structure. And so for the most part, for severe cases of arthritis, absolutely. We will most of the time it shows up on an X-ray and there's no need for any further imaging. But there are times when the location of the arthritis may be hidden by the fact it's a 2D structure. So just in very plain sort of explanation, if we're looking at the front of my fist and the arthritis is where the back of my fist is, then that's what an X-ray is. Whereas an MRI would be able to see the entirety of where things are. And so most of the time, severe arthritis we can pick up on an X-ray, but more subtle sort of diagnoses, more subtle arthritis and different diagnoses of bursitis and tendinitis, we tend to rely more on MRI scans.
Okay. One here that asks, how long after a hip replacement can the other hip be replaced?
An extremely common question I get asked all the time, and the reality is there is no time limit. Often, so I worked for a lot of my fellowship for just under a year in Australia, and very commonly they did both sides at the same time. We tend to have a bit more of a sort of tandem approach to it, which means whenever we are happy, by we I mean myself and the patient are happy with one side, then we proceed to the next side, whether that's 2 weeks because they're someone that recovers extremely quickly, or 6 weeks because they're pretty average and they're comfortable, or 3 months. It really doesn't, there is no hard and fast rule about it. It really is just a matter of feeling comfortable with your rehabilitation. Usually I would say that's around about 6 weeks is when I would discuss it with the patient. And if at 6 weeks anyone's happy and we're happy, then we can list people for that. But no hard and fast rules. Everyone's different in terms of their recovery.
Okay, good to know. And apologies if you've covered this in the early slides, but could you just repeat what causes bursitis?
Yeah, so there is, it's a tricky one because the reality is a lot of the time it can be absolutely nothing at all. It can be nothing that certainly registers with the individual. In other times it can be surgery. So some of my patients after a hip replacement will have bursitis that we have to treat as well as during their recovery. Sometimes it's trauma. So someone falls over and they hit the side of their hip. It's just starts an inflammatory process that then starts the cycle. But sometimes it's seemingly no reason at all. And so there's a full spectrum of the reasons why we as individuals, as human beings, can get bursitis. But the reality is that the consistent ways that we treat it is similar, no matter what the cause.
Okay. I don't know if this is of the same sort of caliber that you were talking about, and apologies for my pronunciation of this, but advice for treatment of chronic trochanteric bursitis. I have been doing regular physio exercises and have had bilateral steroid injections, which have helped for a short time. Is there anything else to ease with the pain?
Yeah, so that's a very typical picture. The one thing I would say that is positive about that is the fact that if the steroid injections help, even if it's for a short period of time, then that's a good thing. It's good from a diagnostic point of view rather than a treatment point of view, because we know that that is where the pain is coming from. And so it's important not to focus on anything else. The important thing is during that period where it is better, that's when I would suggest really we marry up with fairly aggressive physiotherapy. And it's something that I mentioned to a lot of people as to what type of physiotherapy and what aggressive physiotherapy looks like. Well, physiotherapy looks like a tool, but I'm sure that physios would agree with me. The physiotherapy is about 99% with the individual. on their own, following the instructions that the physiotherapist has given them, that there is no substitute for consistently doing the exercises. And that looks like multiple times a day, every day, for a few months. And the reality is that's what tends to break the cycle. Often I find that people engage with physiotherapists who are there as the ultimate guide to help to tweak the exercises and also sort of guide in a very specific way. That's their sort of skill set. But often people feel that is only what physiotherapists or physiotherapy is. But it's all about realigning to the fact that the majority of the physiotherapy is usually with an individual at home doing the work when no one is looking. And that's what's really difficult to do. It's certainly something that I've experienced myself, having surgery. Sometimes I'd wake up and forget that I've done my physiotherapy for 2 or 3 days, and I'm an orthopedic surgeon who should know better. So it's extremely difficult, and often it takes routine. But that sort of routine is usually what breaks the cycle.
Absolutely. On to the next, which says a slight ache in hip flexor when walking, but on waking in morning, no pain. Later in the day, I get bad groin spasms from sitting to standing, or when legs are bent to straightening them. This only happens in the afternoon, then it goes overnight. Been doing various glute exercises as much as possible, and this is helping a bit, but do you know what this could be?
So there are different things it could be. So when this is a classic case of we need the individual to point to where on those depictions that people may or may not have seen where the pain actually is, because hip flexors, some people point to their groin, some people point to their mid thigh. But if we're talking about hip flexor right high up into close to the groin, then again that could be arthritis, regardless of the timing, whether it comes on in the morning or the evening or late at night. It could be arthritis. It could be tendonitis, the psoas tendon across it. So to form a full picture of this, this is where you need an individual in front of me to talk to about it, to examine their hip, which is something that we haven't gone through a lot of detail about today. But there are certain clues in examination of a hip that you can get as to point you into the right direction. So unfortunately, I can't really answer that fully without actually having someone in front of me.
Yeah, of course. And this is a very sort of open-ended question. I appreciate it. All it says is best pain relief. Presume that may be similar case of you'd have to identify where the pain is.
Yeah, well, yes and no. So often I get asked that question, and the reality is pain is the most subjective thing that there is. And there are different combinations and different medications that work in some individuals and don't work in other individuals. And so when it comes to optimizing that, the reality is there's a little bit of trial and error. Now, there are broad concepts. We know that combinations of drugs tend to potentiate each other, so that 1 + 1 = 3, for instance. We know that for inflammatory type tendonitis, tendinopathy, bursitis type presentations, anti-inflammatory medication tends to work. But even within the same classes of analgesia medications, there are some anti-inflammatory medications that work very well for some people and some don't work well for others. And so really it's about trying to find the right combination as part of that analgesic ladder and as part of the conservative end of the spectrum, before obviously getting up to say, you know what, that hasn't worked, and let's go for something a little bit more invasive like an injection, and that can take a long period of time. It can be weeks or even sometimes months to find the right sort of combination that works for an individual. But it's worth seeking, because sometimes it does. If it does, it saves a whole lot more that could be done potentially unnecessarily.
Fantastic. I think you've actually probably just answered this next one, which does say, what other anti-inflammatory drugs are there apart from ibuprofen, as naproxen caused palpitations and had to be discontinued. So
Yeah.
as you were saying,
Yeah,
yeah,
so I mean, there's a whole myriad of different anti-inflammatory medications. Some which are combined with other medications. Some don't go well if patients have certain conditions, heart conditions, lung conditions, sometimes asthma, and that's the reason why the best person to control all this is the GPs, because they have the a patient's full medical history. They have the full picture, as it were, to be able to make the call and say, you know what, actually this anti-inflammatory might not be good, or this one might be. And of course, also protective elements as well, because taking anti-inflammatories can lead to potential issues with the lining of the gut. So the GP can look at sort of giving medication to protect the gut whilst we're sort of tinkering and trying to find the right combination. So all individual, very much run by the GP.
okay. Somebody said, what is tendonitis? I have a strange feeling that something is crossing over a bone on the outer side of my hip. Is this tendonitis?
So the mechanical feeling of something crossing over the bone on the outside of the hip very much sounds like what's called a snapping hip, where the band of tissue that's on the outside of the hip actually just goes either side of the hip. That very much isn't tendonitis in of itself, but if that goes on for long enough, can certainly spark an inflammatory process, which ends up in tendonitis. So in other words, some people can have that pathology without tendonitis. Some people have it with. So I think it very much depends on what the main symptom is. If it is the mechanical element of, that feeling of something moving back and forth, that's one thing. If between times, people are this person's getting a lot of pain, then it may well be tendonitis. So there's a lot more to kind of tease out.
Okay. Someone said, please recommend best physio who can work with active, fit person to help groin pain. Obviously, we've got a whole host of physiotherapists here. But maybe if you could just explain, is it best to go through them first, or speak to you in terms of consultation to identify the groin pain? How best to approach that?
So it depends on how we kind of look at it. The reality is I get all comers, because often I see patients who come from the GP and the physio route, and then to me, or sometimes just to me. I suppose the benefit of coming to me is what I attempt to do is hone down exactly what we think it is before sending it off to the physiotherapist, because there are some broad things that physios can do that certainly will help any type of tendonitis around the hip, for instance. But there is benefit in specifically targeting what that diagnosis is before then sending things to the physiotherapist. Sorry. So I mean, I would suggest coming to see me, but then again, I'm very much biased in that regard. I know that there are some physiotherapists that are doing extremely good work. So certainly here at the Horder Centre, there are a host of physiotherapists that we work with. I know that a lot of patients I see come from far and wide, and there are different physiotherapists that I work with closer to Tunbridge Wells as well, for people on the sort of West Kent side. But to be honest, it's not too far from from here at the Horder Centre, which is a specialist orthopaedic unit. So I'd suggest coming to see me here, or the physios here.
Great. And this person has said, do you know anyone, maybe just a quick explanation of what this is, do you know anyone that offers platelet-rich plasma therapy?
Do I know of anyone? Yes. That therapy is very specific. Now, I'm going to assume that this individual means in and around the hip, because there are lots of different parts of the body that you can give PRP injections into. they're a bit of a contentious type of injection, because there are certain areas that is very well evidence-based that it improves symptoms. So generally around tendinopathy of the Achilles tendon, for instance, some tendons around the hand, there's a lot of evidence that it definitely improves things. There is less evidence around the tendinitis around the hip, and there's even less so evidence of PRP injection into any joint. And so as orthopedic surgeons, we tend to sort of follow evidence-based medicine to stop us essentially doing what we feel is right. And by evidence-based medicine, it is the largest and most robust quality research and trials that's done, that then answer the question, does this drug or does this system or does this thing work best in this situation? And right now we can't say that about putting the PRP injection into joints, and that's why personally I don't do that. Now, when it comes to in and around tendons, really the jury's out, apart from the Achilles tendon and some others where it certainly is proven. So it's not something that I routinely offer as part of my practice, because the evidence isn't there.
Okay, this may have triggered this question actually in terms of other options. Have you heard of cold laser therapy for hip bursitis?
Again, yes, I've heard of it. It's not something that I'm involved in or use. The notion of a lot of therapy like that, with lasers or shockwave or ultrasound or sometimes electricity, they all have a similar concept, which is aggravating the area so that the body almost is overstimulated into sending cells, inflammatory cells to the area to then deal with the problem and then calm the inflammation down. So although it's not something I've personally used, it's something I've heard of, but the broader concepts are the same, but again aren't as proven as some of the other things we talked about, which is physiotherapy, which is the most proven way of dealing with bursitis and tendonitis. It's also sometimes the hardest way because of the consistency that is necessary for it that I talked about before.
Okay. Another one that's quite specific to their pain, so potentially the same answer to what you've given previously. What could pain that starts in the lower back, down the buttock, down the front of the thigh, and down to the ankle be?
So whenever things radiate in that fashion and go beyond the knee into the ankle, the first thing that we would want to rule out is spine issues, because when nerves in the back get aggravated, pinched, get unhappy in any way, they send the pain signals to where the nerve supplies, and there is nothing around the hip from a nerve point of view that goes beyond the knee. And so very much I would suggest that this individual, we'd have to work from the spine forwards, if you see what I mean. Make sure that its symptoms are coming from the spine, and then go on from there.
Okay, fantastic. I think we've got through all of those questions. So thank you very much to everybody who has submitted one this evening, and also thank you very much for your time, and thank you, Mr. Oni, as well, for sharing your expertise. If you did want to learn any more or arrange a consultation with Mr. Oni, please contact our team using the details provided, which is telephone 01892 600 865, or via email, which is the letters pp@horda.co.uk. As I said earlier, apologies for those who didn't see the slides at the beginning of the presentation. You'll receive the recording later in the week. And once again, thank you very much for your time, and enjoy the rest of your evening.
Bye now.
Thank you.